So next generation sequencing is becoming more and more important in oncology practice. And as we think about that, we know that the paradigm is shifting in cancer care. We're really going from an era where we treated disease by tumor site of origin to where we treat disease by molecular phenotype. And sometimes that means a molecular alteration like a mutation. Sometimes it means clear evidence of susceptibility to immunotherapy, but it's clear that cancer care is going more and more towards treatment by molecular phenotype, and that represents a real change. We see that as this last year there was the first indication based on molecular analysis that was tumor type agnostic, and that was really sort of the blanket indication for Keytruda. And we see it more and more as we think about emerging therapies that aren't yet FDA approved, but that are also tumor type agnostic. And so you see that in some of our fusions, in the NTRK fusions, in RET fusions, that we see that these are abnormalities that are present in many different types of cancer. And so the treatments really, again, are sort of tumor type agnostic. So that's important because really since we've had imatinib mesylate for CML, this field has been growing to treat based on molecular phenotype and is growing more and more over time. It's been a clouded and crowded environment because there have been many vendors that do next generation sequencing. You have the FDA approved analytic platforms like Foundation Medicine, Thermo Fisher, Illumina, and the Memorial Sloan Kettering program. But many have sort of done their own CLIA-designated own next-generation sequencing. And so policies have emerged this last year that will help guide us.